and I guess any of us who have been through some, some awfulness can relate to that. But there are ways you come out of that and you are stronger. Does that make sense? People adapt, people grow. So there's this area of post-traumatic growth that's a relatively newer area in traumatic stress. About the last decade or 10, 12 years, a lot of people are writing about this. What is very interesting about this idea is that there's a number of dimensions that they measure ways in which people grow. What would you imagine some of those are? You said, how do people grow from trauma? How did this make you stronger? What are people going? What are your patients going to say to you if you ask that question?
Will they face future stressors, overcome future challenges?
Absolutely. I feel like I can handle stuff now that I couldn't handle before after going through this. What else? One that's pretty consistent is feeling closer to people you love. That's a measure of post-traumatic growth. I appreciate the people I love more because I almost lost them or me or whatever. Another is I feel closer to whatever I believe spiritually. I feel a deeper connection to my spirituality, whatever that may be, as a result of having survived this kind of an experience. Another one that's, and I think, again, we can all relate to this, I put some version of the question, or the answer, I put things in perspective better now than I did before this happened. I have a better sense of perspective on my life and on things that happen throughout the day. So the idea of being able to take perspective is something that people report changes for them when they survive trauma. What's unfortunate is that there are standardized measures of post-traumatic growth, and when you give them, what you see is that even people who score high on post-traumatic growth can also score high on PTSD symptoms. They go together sometimes. So what that says is that this is not simple. There's ways we grow and there are ways we suffer as a result of those. How are we doing so far? Not so interactive.
In the trauma spectrum, would you, is there anything that's been done that puts a borderline PD in this kind of trauma spectrum? Because it's really the similar symptom pattern.
Absolutely. There are a number of people who believe that, particularly borderline, but some of the other access to conditions should be considered as part of the trauma spectrum. I just keep throwing out the controversy. Very controversial. They've done many, many studies of trying to look at trauma histories in clients with borderline personality. Many of these, unfortunately, have been done in the inpatient setting, so you have sort of a slight selection bias. But in the inpatient studies, what percentage of clients with borderline personality would you guess have a significant history of trauma such that would meet criterion 1 in the DSM, 1A?
Half of them?
Half, exactly. About 50% if you average out all the studies of people with borderline personality diagnoses would meet the criteria for high exposure to trauma. Okay, so a lot of people argue exactly what you said, that really that should be thought of. Now there's another group of folks who argue that, what about the other 50%? I think that's valid. What I think the problem is the construct of borderline more than is it this or that. I think there's many different variations of borderline, I think. And I could be wrong, so don't listen to that. But I think we all can relate to the differences, too, when you're treating somebody who has had a history of long-term trauma, who behaves a certain way that gets you called borderline, and the clients who don't have that history, who behave in a way that gets them called borderline. So it's different experiences. Why do we have this idea of complex PTSD, even though it's not a formal diagnosis? Why was it moving in that direction? Why add one more thing to the book? The book's thick, right? It keeps getting thicker every time they revise it.
Yep.
Any of you like group therapy? Doing group psychotherapy?
Yeah.
Nobody likes group psychotherapy. Bad joke. Any of you know Irv Yalom?
Yeah.
Theory and practice of group psychotherapy. When you buy the DSM, you have to buy the new edition of Yalom, otherwise you hurt your back when you carry it. You buy two for the price of one, so they balance each other out. They're both about 800-page books.
Oh my
that, interestingly, when they get thicker, they get more expensive. I don't understand it. But anyway, why add another construct? We have PTSD. What's wrong with that? definition, misses a lot of people who have, and this is probably not the best term for it, who have a history of exposure to trauma over a longer time. And we'll talk about what the criteria would have been. But essentially the criteria are what you're targeting in treatment. So forget what we call it. Let's look at this. This is how people suffer. So we'll look at the suffering. The proposal was not to call it complex post-traumatic stress disorder for a couple of reasons. The term that they were going to use was desnos, which sounds kind of nice and psychological. Disorders of extreme stress not otherwise specified. What is a little challenging is that when you see the criteria, you'll see why. You can have desnos without having PTSD. If this would have made it to the diagnostic framework at that level, you could diagnose this without PTSD, which is a little tricky. So, but this is an interesting story, so let's move into it. Judith Herman, a psychiatrist, many of you may know her work from Harvard, probably has written a classic treatise on trauma called Trauma and Recovery. It's a textbook that almost everyone reads at some point in their training. She also just published an amazing group psychotherapy for trauma manual. If any of you like manualized groups, it's pretty cool. She was one of the people who developed sort of this framework. So let's start with, if we think about PTSD, the first criterion A is exposure. This is the equivalent of that. So rather than focus on the trauma, what she focused on was the trauma context, the context in which a person was traumatized. And the context was in a relationship. So complex PTSD was by definition trauma at the hands of others. Not natural disasters, not car wrecks, but intentionality is embedded in her definition. And examples that she cited, again, look, many of these are adult kinds of stressors, with the exception of child abuse. Right? Political detainment. So you did not have to suffer child abuse to develop this set of reactions that we're going to talk about. But these are just some common examples, not an exclusive list. Then, whoops, sorry. She outlined, or the committee that was working on this outlined a series of adaptations, or call them symptoms if you like. They called them adaptations, that you saw in people who had that longer-term history of exposure to traumatic events in the context of a relationship, or let me say it another way, in an interpersonal context. That's probably a better way to say it. So the first was changes in regulation, alterations in the ability to regulate both affect and impulse. So, anybody thinking borderline right now already? Right, do you see the overlap? Okay, this is really important because it's going to speak to your point. So what are some of the ways that shows up? Obviously, difficulty with affect regulation, explosive entry into affective states, difficulty retreating from certain affective positions. People say, I get stuck being angry, or I get stuck being enraged, or I get stuck being terrorized. I can't get rid of it. Can't step back from it. Can't take distance. Can't use my observing capacity, my observing ego, if you don't mind the language, to really take distance and look at this. I am in it and can't get out of it. So again, the issue is regulation. Modulation of particularly anger and aggressive impulses. Okay. In the DSM-3, this was listed as a criteria for PTSD. Explosive outburst, it was called. Not so much anymore, but modulation of anger. Self-destructiveness and self-mutilation as a way of managing